important content to the public so that you guys can understand how to better serve your patients, how to better serve yourself if you're living with anxiety or OCD, or of course, a family member. So my name is Elizabeth Mackinville. I'm the director of our program, and we're really excited to be here.
I'm Ryan Judd. I'm the clinical director here at the OCD Institute of Texas, and we're very excited about episode 2 in this series. This really, as Liz was saying, this really is all about the presenting in a very user-friendly way the theory and application of cognitive behavioral techniques to anxiety disorders and the treatment of OCD. So today, as Liz said, we're going to get started ERP in practice. We're going to go through the basics and also some more advanced techniques and applications.
So thanks for joining us. Let's hop in. All right. So today we're going to talk a little bit about how ERP fits into the cognitive behavioral therapy model. You will hear us start the presentation. Ryan will get a little bit excited and geeky about CBT. And the reason for this is that we just want to always remember that ERP fits within a CBT model. And so we're going to talk a little bit about that. And Ryan will talk more about why this is important. But once you really understand CBT, you won't be able to unsee it in the way you treat all anxiety disorders and, of course, OCD. We'll also talk a little bit about how you pace ERP appropriately, what some of the fundamentals are when doing ERP. Of course, we'll talk about exposures, inhibitory learning, core fears, and freedom. The big thing I was driving here today thinking about like what are our goals or takeaways for today, and mine that I wanted to start with, and you'll hear me say this throughout, is for us to remember that anxiety is not dangerous. And so a couple kind of buzzwords I want to put in your head are we fighting for freedom over functioning? We will talk a lot more about that. How are we integrating core fear into ERP work? And then we're going to do a little slogan that's through OCDI called WTF, but we really want to focus on what is the function? And we'll talk more about that today, but what is the function of the behavior? And so when patients are feeling confused or you as a clinician are like, I don't understand, what would I do? What would I not do? Sit back a little bit and think about behaviorally, what function are these behaviors serving? Is it serving anxiety and promoting the message that anxiety is dangerous, or is it serving someone's life and their values? And we want to be able to really get them living fully and doing behaviors that fully serve their values in their life and not their anxiety and OCD. What are your takeaway goals?
All of those, and really kind of what you said. I want people to see ERP and how and why it makes sense, because we do a lot of training for clinicians, new clinicians, and even advanced clinicians working in this space that will get stuck thinking through, what's the right exposure, or how should I do ERP for this patient who's stuck, which of course that happens to all of us. But if you really truly understand the why behind ERP, it then becomes very easy and it becomes intuitive because you know exactly what you're trying to accomplish with the ERP, and then you can modify it to make sense for the patient's presentation. So my goal is to get you to really see that big picture of how and why ERP makes sense, the theory behind it, and then it doesn't matter so much the specific trigger, the specific presentation, the specific type of OCD. It's all gonna exposures, they're all gonna make sense to you. Okay.
Exactly.
So yeah, I'll get started with kind of ERP as part of the CBT model. As Liz said, ERP is developed in the family of CBT. It is an intervention used within a cognitive behavioral theoretical framework. And so remember with CBT, what we talked about last time was we're really looking at what are the maintaining factors in this disorder. With OCD, there can be a couple different maintaining factors, both cognitive and behavioral. But what CBT therapists were really good at figuring out was that almost always with OCD, probably the primary maintaining factor is the OCD cycle itself. What does that actually mean, right? The OCD cycle is perpetuated through a cycle of negative reinforcement. So a patient has a phobia, a fear, or an aversion to a particular thought, a particular feeling, emotion, an urge, a sensation, an image. And whenever they encounter that, whether internally or externally, they do something to try to avoid that feeling, that thought, or to make it go away, which would be the compulsion or avoidance or a safety behavior. When they do that, it negatively reinforces that the thought is dangerous, that the feeling is dangerous, that anxiety is dangerous, that they can't handle it, and the cycle reinforces itself and goes on. So to target that maintaining factor, if we know that a person will not get out of the OCD cycle unless it is disrupted, what can we do about that? ERP was developed exactly for that reason. We need to intentionally expose patients to the whatever thought is scaring them, whatever feeling is scaring them, whatever urge or sensation, image, idea is bothering them. However, it can't just be a simple expose you to this
Do it
thought,
once, yeah.
do it once, right? We need to expose you, but you have to then behaviorally respond differently. So rather than exposure to the thought, exposure to the situation, and I do a ritual or I do some safety behaviors, I expose myself, but I allow myself to feel the feeling and I allow myself to think the thought and let it be there and not do any kind of ritual or avoidance behavior. When we do that, the brain learns, oh, this thought is just a scary thought. This feeling is just a feeling. Nothing bad happens. I can handle it. All different types of really good adaptive, beneficial learning takes place. And so this is how ERP is used within the context of CBT to target that, the primary maintaining factor in OCD, which is the OCD cycle.
That's right. I think one of the biggest misconceptions is, oh, it's exposure therapy. And exposure therapy alone, as Ryan is saying, is not the treatment for OCD. If somebody has a fear of contamination and their ritual after they feel contaminated is to typically go wash their hands, they can do an exposure of touching a doorknob that feels contaminated. But if they walk straight to the closest bathroom and wash their hands, they've actually reinforced their OCD cycle. They've given it more power. They've sent the message to their brain and their body that anxiety is dangerous, that this thought is dangerous, that I have to do something to get rid of it. And that exposure, not only does it actually not serve to help decrease anxiety symptoms, it actually reinforces them. And so we want to be really thoughtful and make sure we understand that exposure therapy alone for OCD doesn't work. It has to be done with what we call response prevention, meaning you prevent that response that they typically do to try to feel better.
Exactly. And this is where I see a lot of newer therapists to ERP, to OCD work get stuck, is that they're putting so much emphasis on the exposure part of ERP. And I have to find the right exposure. I have to be, and it's great. You see a lot of really fun energy going into thinking of creative ways to expose the patient to their feared thoughts and feelings. But the exposure is actually really not, as Liz said, the mechanism of change. It's the response prevention. So this is important to keep in mind. What is the role and purpose of exposure? It's actually just as a vehicle to practice response prevention. I really don't care that much what the exposure
Yeah.
is. Is it giving the patient the opportunity to practice what is really the medicine here, which is response prevention? And so that is really important to keep in mind. It's interesting, thinking about patients with OCD, they actually have exposures all day
All
long
day. Yeah.
without even having to go to therapy. That's kind of the definition of the disorder, right? Like their mind is constantly flooding them with these thoughts, these images, or they're out in life, encountering triggering situations, things that trigger their obsessions. So they don't really need
Yeah.
any more exposure. They really need exposure with the intent to practice response prevention, right? So don't worry so much about how can I, what exposure is the right one, and worry more about, does the patient understand the rationale, and are they actually doing response prevention?
Are they removing those behaviors that are keeping them stuck? And I want to take a second before we move on to just generalize this back to CBT, but we're sitting here giving this presentation in this really hot room. The AC is not working in here, so it's very toasty. And as we're sitting here, I start like 2 minutes ago, I'm like feeling my body's feeling hotter. Like this is going to be miserable. How are we going to last an hour, right? And when you just think about even that exposure slash experience that's happening right now, do I want to apply CBT concepts to be able to kind of accept that, like, okay, yeah, it's kind of hot, this sucks, and what are we going to do about it? Nothing. We're going to keep giving a presentation, we'll make the best of it, and maybe I'll feel a little bit of the cool breezes here and there. Or am I going to behaviorally reinforce the fact that I feel hot the whole time? Am I going to continue to scan my body, think about it, look at this broken AC unit, wonder why it's not working, look and see if Ryan's feeling hot, right? Like, we actually all use CBT, or we don't use CBT, and we should, throughout our day. Exposures happen, things happen. You get a triggering email from a boss, you get a text message from, somebody that you care about that's frustrating. And so how are you responding? Are you responding in a way that's giving that anxiety, those thoughts more power, and are actually taking you away from being able to do the presentation or live your life or do the important things? Or are you responding to anxiety and even uncomfortable feelings as if they don't really matter? And like, yeah, they might suck, but who cares? And we figure out how to move through them.
Great. So I think it is really important to talk about the pacing of ERP. If you've got a patient, you're pretty sure that you're dealing with OCD, and they need ERP, which is, of course, the case if they do have OCD. Pacing is really important. This is another kind of common pitfall that I think newer clinicians fall into is that you really want to help your patient. You're like, yep, this is OCD. They need ERP. And you kind of jump right into ERP without laying some of the really important groundwork that needs to occur first. So we thought we'd really talk a little bit about pacing. What does that look like? So I'll let you say a few things about this, Liz.
I think historically, a lot of times, and even with younger, newer clinicians, I still recommend using what we call a hierarchy, where you're really developing a hierarchy is kind of the concept of you're developing this ladder of exposures where you're taking a patient and saying, okay, and you're ranking exposures on a scale of probably 0 to 10, 10 being the most triggering, 0 being no anxiety at all. And you're saying things like, okay, how hard would it be to touch the doorknob in the studio and not wash your hands? And maybe they say, oh, that would be a 3. And you put it in this hierarchy as a 3. And then how hard would it be to touch a bathroom doorknob? Maybe that one's a 7 and a hospital's a 10, right? But you're ranking the exposures based on how anxiety provoking they would be. And the reason we do this is because we do want exposures to be systematic. And if you say to me, well, why? Like, is it dangerous for someone to start with a 10 versus a 2? No, it's actually not. If they're willing to do a 10, great. But the probability of someone's coming to you because they're living with anxiety, an anxiety disorder or OCD, that they could start with a 10 and do it with response prevention is actually very low, right? That probability is low because if they could do that, they'd be doing it. They don't remember last week or last webinar, we talked about this is ego dystonic. They don't like the disorder. They don't like the thoughts. And so they're not wanting to have them, but the anxiety is what causes them to give in. And so the reason we do slow systematic exposures is because we want the exposures to be done with full response prevention. As Ryan said, the response prevention is much more important than the exposure itself. And so Alec Pollard will talk a lot. He's a great clinician at St. Louis, but he'll talk a lot about he would rather all day there be a small E and big RP than a big E and small RP, right? Because one will still reinforce the cycle, the other one won't. And so that's the concept. The concept is that we slowly work our way up to it. Exactly. The other concept is that this is not, we'll talk about this later, but like this is not about fear factor. The goal is not, let me just see how triggered I can get you. The goal is that we experience and move through the world. What Dr. Perry, who's a trauma expert, would say is like, we want people who are everyone's going to experience trauma in their life. The goal is that you actually are slow dosed to trauma instead of you have a big dose and then you're not able to respond appropriately and you end up developing PTSD. The slow dosing is the same with an anxiety disorder and ERP, which is that we want to give it to you at a dose that, yes, it's still going to feel really scary and it's going to be challenging, but we want you to build confidence, build your ability to do response prevention, and slowly be able to work your way up to doing that successfully. Think about it as a simple behavioral activity like teaching a kid to ride a bike. You don't start on day 1 and give them a bike without training wheels and just say, go ride your bike, right? You have them practice, there's a stepwise process to then being able to remove the training wheels. And by the way, that's still scary when you do it, but there's a stronger chance they're going to be able to be successful.
Absolutely. And a really important point here is that when part of this process, there's been a little bit of a misconception for a while that, OCD work is all behavioral. It's primarily behavioral, but there are cognitive elements to it. One of those being processing an exposure after it happened. What I mean by processing is not kind of what you hear typically like, oh, let's talk about how you feel. No, we're processing. What did you learn? What was that like for you? What was different than what you expected? So if we start with a smaller exposure, that's a little bit easier for the patient to tolerate and do response prevention effectively. Then we want to really process after the fact. What was that like? What did you learn? And you can see people, number one, start to challenge those beliefs they have about something bad will happen, or I won't be able to handle it, or it'll be too much for me. Or I won't be able to do response prevention, and then they actually are able to. You also see their sense of confidence build in the process. So those higher level exposures on the hierarchy become naturally less distressing even before they get to them.
That's right.
The other thing that's really important to keep in mind here with the pacing is that you really need to make sure that your patient understands the why. Psychoeducation is, in my opinion, and I think Liz would definitely agree, is the most important part of this whole process, even more important than the ERP. And the reason why is because the patient doesn't understand the rationale and the why, and they just jump into ERP, even with a good attitude, it's probably not going to work all that well. They need to understand why they're doing this, why it makes sense, they're way more likely to actually do the response prevention if they understand how it's going to help them and what the goal really is, right? Again, because patients come in sometimes thinking the goal is fear factor
Yes.
because that's what they've heard or that's what they've read about it. And that's absolutely not the goal, like Liz said. So we need to make sure that psychoeducation is a huge part of the early part of treatment. While you're starting to develop the hierarchy, you can kind of do it together, weave that into it. But I'm always checking for understanding. I'm
That's right.
always checking for understanding. Ask your patient. So explain that to me. I just explained to you where you're getting stuck. Why are we doing ERP? What's the purpose? Why is response prevention important? Why is the exposure not as important as response prevention? What are we really trying to get you to do here? You want to feel confident that they can repeat that back to you, that they have an understanding, they can explain it, and they see the connection before you really proceed with active ERP.
100%. All right. So what do exposures actually look like in practice? And I always like to give a real life example of this. But if my kid is afraid of something, I don't decide that I'm going to throw that feared object in their crib with them at night and figure that like, okay, they'll just, get used to this and this is how we do it. That would actually be traumatizing, right? That would be scary. They would probably be more afraid of that item and they would not develop a better learning experience, right? They most often than not actually would become more fearful versus less. Instead, if my child is afraid of something and I'm trying to get them to approach it, what do we do, right? As a parent, what do you do it with them? You approach it together. You sit on the floor. You play with that object. You model. I'm not afraid of this. There's not a reason for you to be afraid of it, right? We slowly show you. And ERP is very similar. ERP should be collaborative. You should be doing it together with your patients, and you should never be asking your patients to do exposures that you wouldn't be willing to do. This is really important. I see this all the time on forums or with clinicians of, oh, would you have your patient do this or do that? And it's things that a lot of times they're like, I would never do it, but like, why not tell my patient to do it? Well, because then like we're just trying to see these kind of crazy activities versus doing things that are actually make sense, number one. Number two, does it make sense to your patient? When you're talking about developing exposures, the most important question you should ask is, what are you currently avoiding? Right? What are things that you're not doing because of your anxiety or OCD and that you're afraid of, but that if you didn't have anxiety or OCD, you would be doing? That we turn those things into exposures and we start there.
Absolutely. Yeah. So, what are you avoiding is often the best question to start with, because things that people are avoiding are usually the things they want to be doing but are afraid to do or feel that they can't do. We'll start there. Some other areas that you can look at are, where are they most impaired? Again, most people will have kind of a natural motivation, desire to become more functional again. They don't like that they're having to give up certain parts of their life or certain activities. So we're going to say like, where are they most impaired? What are they avoiding? What are they you can ask them too, what are you motivated to work on in the beginning? And that might not be the area of most impairment or the thing they're avoiding the most, but if they're really motivated to do it, let's say it has some kind of special meaning for them, tied to one of their values, then great, we'll start with that as a way to build rapport and build confidence in the method, in the ERP itself. Also, we'll talk more about values-based ERP, but if we're really linking all of this back to like, why is this important to you? What kind of a life do you want to be living? What are the ways OCD and anxiety are currently stopping you from being able to live that life, to live out those values on a daily basis? People are naturally, again, more motivated to do the work because it's hard work.
Yeah.
And so we want to start to discuss that concept of values-based ERP early on in treatment as part of psychoeducation and developing the hierarchy.
Yeah, and values-based ERP is exactly what Ryan's talking about. It's the concept of how can we help individuals see that the goal of ERP is that you get closer to living the life you want to live and that you eventually get to a place where you're living the life you want to live, not dictated by your anxiety, OCD, or fear anymore. And we want to make sure everything we're encouraging a patient to do, we're asking them to do aligns with this, meaning that it is not, hey, oh, you're afraid of random contamination. Let's just put urine in water guns and have a water gun fight and just get you triggered and do something gross just to do it. That, again, what is the value? What is the use in that? But might I have someone touch urine to a degree? Maybe if my fear is changing my kid's diaper, I am going to have I am going to change my child's diaper as part of exposures because that's a value. I want to be able to change their diaper. And guess what? I may come in contact with urine in a way that my husband and, caretakers and anyone else might if they're changing my child's diaper. So again, we never can say, okay, you should never do anything like this. You should never have someone touch urine. But it's like, again, what contextually does it make sense? What is the function here? We're going to ask this question again. When you're thinking as a clinician about developing an exposure, what is the function of that exposure? Does it get the person closer to their life that they want to live? Does it make sense for them? Are they telling you, hey, this would be valuable? I know I need to do this, right? Our patients should actually be saying things like, I need to add this to my hierarchy, or I need
Yep.
to add this to my list of exposures, or hey, here's something I'm avoiding that I really don't want to avoid anymore. I want to be able to give my son a bath and not drain the bath water 3 times because I'm afraid there might be urine on it. I want it in it. Okay, well, how do we slowly get there and what does that look like? But again, my 3 rules for exposures are I should never ask you to do an exposure that I'm not willing to do. Number 2, we should be doing them together. It should be collaborative, at least early on, as you build trust and rapport, and it should feel like something we can do together. And number 3, it should never be a surprise. We don't surprise trigger people. We don't do this in this cruel kind of mean way. It's you know about it, I know about it, we're talking about it, and then we go do it together. And our goal is that when we do that, when exposures align with your values and they're done in a way that is not just ethical, but that's very collaborative, 9 out of 10 times patients will say things like, it wasn't as bad as I thought, or wow, I really learned so much, or I can't believe I can do that. Let's keep
Yep.
going. And that
Yep.
motivation and willingness increases.
Absolutely. Yep.
The last thing I'll say before we move on about values-based ERP is that exposures shouldn't make people feel worse. They should make people feel better. And that's usually a red flag for me. If a patient says, hey, I've been doing ERP and it's making me feel more depressed. It's making me feel really sad. It's really like I don't feel good doing these. Sit down and ask why. Don't just throw ERP away. Don't throw that exposure away. You'll see this later on. Ask why. Figure out what's going on that's making this not align with your values or that's making you feel really triggered and down and about versus it being hopeful and a good
Yeah.
exposure.
And just a couple, reasons why that could be that come to mind. I'm sure there's a lot, but 3 big ones come to mind. One is the exposure not a good exposure? Is it not
Yeah.
value-based? Is it not actually targeting what you want to be targeting from that CBT model? The second one would be, is the patient not doing response prevention? Because of course, like Liz said earlier, I can't stress this enough. A patient doing an exposure with rituals is just doing OCD.
Yeah.
That is literally just making OCD worse.
And that will make you feel bad.
And that will make you feel
Really
bad.
bad.
And this is the thing that patients aren't always willing to hear right away, although some do. But the truth is that what makes people feel bad are the rituals.
Yes.
And that's what makes we kind of talk about the OCD cycle in reverse, that you're having obsessions because you're doing rituals, because you're avoiding things. Not always the other way around. The same thing, the rituals and holding on to the rituals are what make people feel bad. And so if someone is talking about, I keep doing this exposure we agreed on, but I feel worse and worse, that could be check for that. They're probably doing rituals, and that's what's making them feel bad. And then the third potential reason why is that there's a gap in psychoeducation.
Yeah.
And like I said in the beginning, you want to really lay a solid foundation of psychoed, but you have to keep checking for understanding as you go. Of course, you're adding in more concepts. The patient is understanding it more and more deeply and personally as they're experiencing it. But sometimes they don't get the rationale of why the exposure or why the response prevention, and that can come out in that way that, oh, the exposure is not going well. I'm not feeling better. So those are a few things to check if that's what you're hearing.
Yeah, the only thing I might add on too is I do think sometimes when people don't fully understand ERP, clinicians, they just think of like, let's go to worst case scenarios. And they think that ERP treatment means, okay, let's touch this thing and let's lean into the fact that the thing you're afraid of is going to happen. And so patients are doing exposures and they're leaning into like, okay, I am going to get sick. I am going to die. My life's going to be ruined. I'm never going to be able to experience joy. That would make all of us
Yeah,
feel depressed.
exactly.
Like we'd all
Yeah.
feel pretty sad. That's actually not how ERP needs to be done. ERP, by the way, you can actually not lean into your worst case fears and have a more meaningful exposure. It can actually be more triggering. The goal is that we're leaning into the unknown. We're stopping trying to figure it out. So, for example, if this is contaminated, I'm touching this contaminated book, I'm letting all those intrusive thoughts show up. Those thoughts around, what if this book is contaminated? What if I get sick? What if something bad happens? So I let those thoughts kind of show up. I slow down enough to say, okay, I'm having these thoughts that I'm getting contaminated. I might die. Something might happen. And I'm going to choose not to figure that out. And I guess if I get sick, I'll deal with it later. And then I move on instead of, right? So, you shouldn't be doing, I am definitely going to die. I'm definitely going to get sick. I'm never going to be able to live
I'm a
the
bad
life I want.
person.
I'm a
I
bad
hear that a
person,
lot. People are doing, these scripts or imaginal exposures. We'll talk a little bit more explicitly about imaginal exposures where they're telling themselves, yeah, I have to be okay. I have to learn to be okay with that I'm a bad person. Well, I don't think most people could habituate to that, right?
And we
Like
don't want
we
them
don't
to.
want them to. So, again, it's kind of like the rule is set about, don't do an exposure that you don't ask a patient to do an exposure that you're not willing to do. Same with response prevention. If you're like, well, I wouldn't be okay trying to be all right with that I'm a bad person, accepting that versus accepting you're having the thought that you're a bad person.
Right.
The idea that you're a bad person, is
Make
it
it bigger
okay?
reality.
Yeah, is that okay that your brain sometimes tells you you're a bad person? It's a thought. It doesn't feel good, but it's a thought. Can we
Yeah.
treat it like a thought rather than you don't need to accept that that is who you are or what you are?
Yeah, I was telling Ryan, I thought one of like the funniest things recently is I asked my husband, I was like, do you have intrusive thoughts about our kids? And he's like, yeah, Liz, all the time. And I was like, oh, why have you never told me? He's like, why would I tell you? They're just random thoughts, right? But again, someone with OCD, they're struggling to just let thoughts be thoughts, right? They're behaviorally reinforcing them, they're talking about them, they're telling people, they're triggered by them, they're anxious by them, and that's what's giving them power. What we're asking you to do is what people without OCD do. They have thoughts and they just let the thoughts be there. They don't try to solve them. They don't try to do anything about them, right? We always tell our patients with OCD, compulsions will make you more confused and trying to solve will keep you stuck. We need to get you to stop compulsing, stop trying to solve, and just treat that thought as a thought, which is it's a thought. Who cares? I'm moving on. I'm doing nothing about it.
Absolutely. So, the other thing to keep in mind when you're designing exposures for a patient is this inhibitory learning model. So there are a couple of theories of why exposure therapy, ERP specifically work. We know that they work. We can observe that through lots and lots of research and evidence. But the question of why, there's some different theoretical hypotheses. One of them originally was the idea of habituation, that patients get better when they expose themselves to feared things, especially if they're doing response prevention, because they habituate. It goes from being highly distressing over time to less distressing. Kind of the idea of like you get in a cold pool or, a pool that feels cold, but if you kind of wait it out, eventually you regulate and you no longer, it doesn't feel cold anymore, it feels comfortable. And habituation for sure happens. It often happens. It should happen if the patient's do, especially if the patient's doing response prevention. But but we really learned that there's also another mechanism going on at the same time, which it or could be going on, which is inhibitory learning. The idea that when a patient's doing an exposure, they're doing ERP, they learn something new, which is that I can approach something that's scary and not do what I normally do, which is a ritual or some avoidance technique, which doesn't necessitate that their anxiety goes down. It should go down, but maybe it doesn't. Who really cares is the point. What's more important is they're learning they can do this and they don't have to do the OCD behavior. That, from a CBT, what's the maintaining factor standpoint, is way more important. What also is more important, why else this is really important is because if we're really putting the main focus on habituation, that in order for an exposure to be successful, the patient's anxiety needs to go down. We're kind of undermining our own message, right? We're kind of sending the signal to the patient that like anxiety is dangerous. You are stuck if you don't feel good all the time. Thoughts are only safe if they don't bother
You
us.
can only move on when you're not triggered anymore.
Exactly. So we would really kind of be shooting ourselves in the foot if we're only putting the emphasis of ERP successful based on if you're habituating. We've really fully transitioned to a more inhibitory learning heavy model where we're placing the emphasis on the patient of the exposure is successful if you learn that you can handle it and you can also do response prevention effectively and 100%.
Yeah, so I'm going to throw a little thing out there, a little like thing to think about is are you still using SUDS? And if so, why or WTF? But what is the function, right? But like kind of WTF too, but like what's the function? If you're using SUDS, you're saying, "Oh, I'm on board. I understand inhibitory learning from a CBT lens. That makes sense. We want people to have new experiences. We want them to learn that they can do new things." If you are still focused on SUDS, so SUDS stands for Subjective Units of Distress Scale. And back in the day when I first received treatment, when I was first doing treatment for many years, and you would do things like, okay, Ryan, we're about to start an exposure. What are your SUDS level? And he would say, oh, I'm at 8 out of 10. And then we'd start the exposure and I'd be asking throughout, what's your SUDS? What's your SUDS? And our old school kind of like benchmark was we want SUDS to reduce by at least 50% before you can move on. And many of you who are trained in this old model, because you're like, well, yeah, isn't that what we still do? I want you to really ask yourself, Why am I still doing that? Because again, what is the function of measuring SUDS, right? As a clinician, it might be, oh, because I want to know that it's working, that they're not, it tells me usually if their SUDS are reducing, that they're not doing a ritual, that they're getting a new learning experience, right? We can kind of measure those. But what's the function that it actually serves to your patients? What it does is it teaches them I can't move on till my anxiety reduces, and that anxiety reduction is the measure of success. Where what we're trying to tell them is it actually doesn't matter if your anxiety reduces or not. What matters is can you do something you didn't think you could do, and can you learn to move through that? Why? Because in life, your anxiety is going to be at different levels. There's going to be different time, right? Kind of think about that pool example. A pool is such a great way to think about habituation, right? Those kids that are, tiptoeing in and they're making the habituation process miserable versus the kids that just jump off the diving board and they immediately habituate to the pool. But if you think about it, the same thing can happen, but depending on how you behave throughout, you're either reinforcing the temperature of the pool or you're literally acting as though you don't care about it. The kid who dives in is acting as though he doesn't care because his value is having fun and diving in the pool. The kid who is tiptoeing in, they never get their head under, and the whole time they're like, it's still cold, mom, it's still miserable, this is awful. They actually don't have a good swimming experience, even though you made them do the exposure. Why? Because functionally, what was the function? They were still worried the whole time about the pool temperature versus the value. And so when we measure SUDS and we measure anxiety levels, we're ending up sending that message, often unintentionally, that like the functional thing that actually matters and that what you actually need to be worried about is how you feel. And that is fundamentally against all CBT models, right? The CBT model is that like you can have thoughts, you can have feelings, and you can choose to behave differently despite those, right? I can be triggered and still choose to do a values-based activity. I can have a hard conversation or not want to have a hard conversation, but still have it because that's important and have a new learning experience that, oh, it didn't go as bad as I thought, or oh, that was still really useful. So again, when we think about inhibitory learning, we're really thinking about not just the process of like, yes, we're learning something new and what happens, but what are you doing along the way with your patients that are reinforcing inhibitory learning and promoting it to happen and to take place versus the things you might be doing, even unintentionally, that could be keeping them stuck. So I'm going to throw out there for clinicians to start thinking about like, what is the function of using SUDS? And by the way, that doesn't mean I don't ever ask anxiety levels. Sometimes I do because I want to know, because especially as I'm getting to know a patient, people show anxiety differently. I want to know like, how anxious are you feeling, right? Especially if I'm doing systematic exposures, but it's not the main point. It's not really even a big point in our conversations and in our exposures with patients anymore.
Exactly. And like Liz is saying, I think as clinicians, you can keep it obviously in the back of your mind that you're observing to see, or you do ask sometimes, but more for your own internal purposes of judging, like, because again, we do know that if a patient's doing an exposure with response prevention, they should habituate.
Yes.
So I do want to see if they're super anxious still, but I'm noticing that I'm not necessarily asking them. I can point it out, hey, you look really anxious. What's going on? Are you doing rituals in your head? Are you
Yeah.
doing mental rituals? Are you holding on somewhere? So I'm of course, going to use the patient's anxiety level subjectively, what I can observe or ask them for my own clinical purposes. But I'm not tying it back to the patient directly saying, hey, well, it must not be going well because you're not habituating or, oh, So that's where we're putting the emphasis and how we're using it in session is really important. The other thing, like Liz is saying, we're looking at maintaining factors. Oftentimes, one of the less primary maintaining factors here with OCD, also with all the anxiety disorders, is the person's already hyper focused on how they feel. They're already really oversensitizing themselves to minor sensations in their body and faulty interpretations of what that means. We're challenging that. That's part of the treatment. So by using a really habituation exclusive model, I'm actually just reinforcing that, oh yeah, you should be paying attention to all the little minute sensations in your body and interpreting them catastrophically or in an unhelpful way. So you can see how inhibitory learning, again, more aligns with this overall CBT model that we're using to target lots of different maintaining factors in OCD.
Yeah, and so I always like to say inhibitory learning is the new way that we want to teach patients, but we still expect habituation to happen.
Absolutely.
It's
Yeah.
not like, oh, we throw habituation out. No, we still want people to habituate. I want you to not be anxious. I want you to not be triggered. That's still the goal of treatment. But we don't put the function of doing ERP is not on habituation because the more we try to make sure we're habituating, the more we can guarantee we're not
Yeah,
going to
exactly.
habituate,
Absolutely.
right? Habituation happens on its own when you actually least expect it.
Exactly. And you let go of needing to feel better, of needing to feel less anxiety.
Yeah, so one thing nobody talks a lot about, and we'll probably do an entire webinar on core fears because I think that it's very nuanced and it takes a lot of time, but I wanted to just start to plant the seeds, is how we integrate a core fear model into ERP. And what we mean by this is that, a lot of times patients will come and they'll say, listen, I've done ERP, I understand ERP, and I can see how it can work for the things I'm triggered by. However, OCD feels like this game of whack-a-mole, right? I address one thing and another thing shows up and another thing shows up, and I'm just constantly having to do ERP for my triggers. Or you'll have a clinician come and say, hey, Liz, I've been working with this patient, and every week it's like the new crisis of the week, right? The new trigger, the new thing, and they're not really generalizing. They're not really able to use ERP across the board. And like it hasn't really sunk in that anxiety is not dangerous, that they need to quit reinforcing, their fears through their behaviors, that sort of thing. And that's where and why it is so critical that you integrate core fears. And what we mean by that is we do not tell a patient, right? There's a big difference. And if a doorknob near me is contaminated, if I want to use kind of a traditional fear extinction model, right? What would we do? Okay, well, I would have you do exposures with response prevention. I'm going to have you touch that doorknob. That's the exposure. Often and frequently, and I'm going to have you do response prevention 100% of the time. If you usually wash your hands, I'm going to ask you not to wash your hands. And eventually, if you keep touching that doorknob and not washing your hands, that doorknob will no longer feel contaminated. You won't be afraid of it. But the problem is that for patients with OCD, there's thousands, if not hundreds of thousands of doorknobs, right? Triggers and different things. And it's constantly shifting and moving and feeling like this game of whack-a-mole. Okay, here's my 100 things and I do them, and then here's another 100, and it feels never ending. And the reason for that is because you're doing a fear extinction model, you're doing like surface level ERP versus actually doing ERP that targets the thing that causes all these other triggers, right? And so what I mean by that is we're still going to touch the doorknob, we're still going to not wash our hands. But I also want us to lean into what is the core fear that made that doorknob contaminated? So maybe for a patient, it's something like, well, I'm afraid that I'm going to get sick. And if I get sick by touching a doorknob, I could get someone else sick and I wouldn't be able to live with the feeling of causing someone else to get sick. All right, so touch the doorknob, don't wash your hands, slow down, and let your thoughts kind of show up naturally. Those thoughts of, what if I get sick? What if someone else gets sick? How will I be able to live with this? I don't know how I could tolerate it. That would be so uncomfortable. Like, let the thoughts show up and choose to not answer them, but be able to spend some time with them. So that doesn't mean you say, oh, yeah, I'm definitely going to get sick and I'm going to kill someone and my life's going to be ruined. But it's about being able to say, okay, I'm really triggered right now that by touching that doorknob, I might get sick and get someone else sick. And it's really scary for me to think about having to live with that feeling and like
Yeah.
live without knowing. But I'm going to choose to not figure this out. And if this happens, I guess down the road, then I'll deal with it when I need to deal with it, sort of thing. But you're slowing down and letting space for the thing you're actually afraid of to be there. And if you do that, ERP will have a domino effect. Now, the thousand other triggers that I have and the thousand other rituals that I do for that same fear of having to live with guilt of causing harm to someone else, or having to live with the fear of having to live with guilt or anxiety forever will start to wipe away, and you'll start to see ERP generalize across different triggers.
That's so well said. And so really, if you think about what Liz is saying here, a core fear model of ERP is really just saying, when you boil it down, that you need to make sure what you're targeting with ERP is actually the relevant fear, right? We're not using, as you were saying, a fear extinction model. Really, I'm thinking we're not using a trigger extinction model, right? Like we're not trying to get rid of all
Right.
your
Yeah, better
triggers,
model. I like that.
all the doorknobs, right? We're trying to get rid of the actual thing that you're afraid of,
Yeah.
which is always going to be a thought or a feeling or a combination of both, right? It is an idea. In the example you gave, the idea that maybe I'm a bad person, I feel guilty. What if I caused harm to someone? That's what you're afraid of. Now that shows up, that idea, that feeling shows up lots of different triggers. We're not going to go after all those triggers. We're going to go after the actual idea behind the triggers.
Yes.
That's what we mean by core fear. This is really important because I do think that there are a lot of misconceptions. We hear this word used. Different people use it in different ways. It's very important that we're really rigorous about how we're using this term. It doesn't mean something psychoanalytic like what happened
Right.
in your childhood that like is the core of your OCD. No, we're really just saying what is the actual underlying, if we boil it all down, what is the
What do you
the
actually afraid
idea
of?
exactly that you're afraid that you,
Yeah.
you feel like you can't sit with, and so you're doing all of these things to try to make that thought go away or prove that it's not true. Instead, we're just going to target that directly And then, like you said, it should domino and it should go across the board.
And the last thing I'll say when we move on is we're still going to target it through exposures, so we're still going to do some exposures and things you're avoiding and target the core fear. I say this because I see some clinicians sometimes be like, oh, well, then we don't need to do exposures. We're just going to talk about the core fear and we'll talk our way through it. Your patients have tried to talk their way out of it, right? I promise you, if a patient with OCD is showing up in your office, they have tried to talk their way out of it. They've tried to use logic. They've tried to understand it in a like bigger way or theoretically. That doesn't work for OCD. We have to do behavioral change, which is why we still have to do exposures at the same time. Okay. So what is the goal of OCD and treatment management? And this is so important because, I think traditionally a long time ago, we would have a definition and talk about OCD as being this chronic pervasive illness that you'll have for your entire life, but you can learn to manage it with effective treatment. I want us to really think about what that does, the message it sends, and the way it actually holds our patient population back from obtaining freedom. ERP, if done correctly, if we're targeting core fears, if we're helping a patient truly change their entire relationship with anxiety and OCD, if they're generalizing CBT concepts across the board to their life, it should get them freedom from this illness. It should not, the goal should not be, I'm going to help you function better while struggling or while still living with and having anxiety and OCD. The goal should be, we are going to get you to freedom. I always say my goal is, and the goal of freedom is like, can I get you to a place where you have thoughts, but they're no longer triggers? Because everyone's going to have thoughts, everyone's going to have anxiety. But if it no longer plays a role in your life, it's no longer triggering you, it's no longer making decisions for you, that is a place of freedom.
Absolutely. Yeah. And really what you're describing, which is always our overall broader goal here with CBT, is that we're asking what we want to see happen is patients change their relationship to their thoughts and feelings. Anxiety, it shows up, it's no longer dangerous, it's no longer bothering me. Thoughts show up. They're just thoughts. They're just ideas in my head. I don't have to take them seriously. I don't have to be afraid of them. When you see someone make that shift in their relationship to their thoughts and feelings, which by the way, that's kind of transdiagnostic with CBT.
Yeah.
It's kind of what we're doing with all disorders. This is how it looks specifically with OCD. When you think almost like of a phobia, if you had a patient come to you with, a fear of riding elevators, you wouldn't be happy if you just got them to ride elevators, but every time they took one, they were still terrified and just like white knuckling through the ride. You'd feel pretty bad about that. Yeah, you got them more functional, but they're still suffering tremendously. That's like functioning. Freedom would be, I am no longer like I get in an elevator, I don't even think about it. It doesn't bother me.
I
Like,
can do other stuff. I can check emails. I can,
yeah, yeah.
in an elevator,
I'll
have a
ride them all day.
conversation, be
Yeah,
present. Yeah.
exactly. Right. So that's freedom versus just like let me white knuckle my way through life. Let me just like suffer a little bit less through OCD. No, we want full freedom from this.
Yeah. And so again, we want to reframe it. We want to help patients see it's possible and we want to give them those experiences. Be careful because I think there's a lot out there right now on social media. There's a lot of advocates and a lot of individuals that are really still struggling and they're sending the message that this is what recovery looks like. We want to make sure we are sending the message to our patients that freedom is what recovery should look like. It's what we're fighting for. And we want patients to be able to identify, right? By the way, not all of our patients leave. We run a residential program for anxiety and OCD and a day program. So we're treating the most severe patients. Not all of our patients leave totally free from OCD. If they did, we probably kept them here too long, right? They leave much more functioning. But the goal is that they've become more functional, but they clearly know how to get to freedom. They know what they still need to do, where they're still holding on, how they can lean in to have full freedom and the path it's going to take for them to get there. So, it's about a process. We don't expect freedom to happen overnight, but we want patients to expect, to know, to plan that that is possible and that that's the goal.
Exactly, 100%. The process takes time. It's so worth it, but consistency is really a big part of that and continued commitment to the process. The understanding, once you have it and you've really integrated it and generalized it through active ERP and core fear work, then you've got what you need to go on and finish the work and see the process through.
Yeah. All right, this is my favorite slide and the most important, and I think the one we're ending with before we hop into questions. So please make sure to put any questions you have in the chat. When ERP isn't working, instead of us saying ERP is the problem, please, I beg you, ask why it isn't working, right? Nobody in the real world, when something isn't working, just gives it up. Sometimes you do, but like, and that makes a difference in your life. You need to figure out why did that not work so that you can have a new experience next time, right? If I cook a new recipe and it's horrible, I need to figure out what happened, what went wrong if I want to try that recipe again and have more success versus continuing to try the same way and it continuing to be horrible and me reinforcing that this is a really bad recipe, right? Even though maybe I love the way this recipe is made by my grandma, and it's where I took it from. So slow down and figure out, why is ERP not working? Number one, is there a comorbidity that you're treating as OCD and it's not? We see this all the time with personality disorders, with even comorbid like GAD being treated as OCD when really it needs a more GAD specific intervention, right? But like, or is the patient not actually doing ERP? Are they doing rituals the whole time? Are they white knuckling their way through it? Are they holding on? Why is ERP not working? And I'm not saying that ERP is for everyone, because it's not. Sometimes, by the way, ERP is not for you as a provider. If you feel like you're going to struggle to not be anxious yourself, or you haven't done your own work, sometimes it's a hard intervention because it causes your own distress and anxiety if you haven't managed that you need to do that work first. But the reality is, and I will say this until I have a different experience, but I've been doing this work for decades. I've treated many patients across the spectrum from treatment refractory to mild OCD. I have never seen someone with OCD have their OCD not change and get better with ERP if they were actually doing ERP. Now, I've seen people do ERP with 1 foot in, 1 foot out, where they do some exposures, but not full response prevention. I've seen people go and do what they think is ERP, and the provider's actually not doing ERP. They're just doing this like fear factor, or they're reinforcing through reassurance, that they're doing with the patients, right? There's different things. But true ERP, mechanistically, Ryan and I talk about this all the time, it doesn't make sense why it wouldn't work.
Yeah, exactly. I mean, and that's why, you think about, will there ever be a different treatment for OCD? I don't think it's possible, because what we're literally, OCD, if you boil it down, is a fear of thoughts and a fear of feelings. Specifically thoughts that's being reinforced. Exactly. So how could you find something that would stop the person's brain from having scary thoughts without them actually being willing to expose themselves to them?
Yeah.
It's almost like a physical thing. You couldn't possibly physically do it any other way. And why would you want to? And I say this a lot too. Any provider that's had success with ERP, if you're doing it the right way, and your patients actually have OCD and they're willing to do it, you fall in love with it because you see that patients they benefit so much from it, not just their OCD, but their self-confidence, their sense of self, what they believe they can do. And so I'm almost like, why would anyone want to take that away from someone if it's what they really need? Now, like Liz is saying, sometimes ERP is not working because maybe the patient doesn't have OCD, right? Maybe,
Or it's not what's primary. Maybe you have OCD,
primary,
but you have a different primary disorder, and like ERP actually wouldn't be warranted, right? If you have really active BPD and you're self-harming every time you get dysregulated, if you have an active substance use disorder and you're, using substances every time you get dysregulated, ERP wouldn't be warranted first, because ERP does dysregulate you, right? It makes you feel anxious temporarily and feel triggers that you've been avoiding or trying not to feel. So there's times where you wouldn't do ERP yet, but ERP for OCD, if you really understand ERP at its core, and it doesn't make any sense why it wouldn't work. And I, again, have yet to see that ever happen. I've yet to see somebody with OCD do the ERP and it not work. And so I want us to be thoughtful about that. Yeah. All right. I know we have lots of questions, so we're going to hop in. And the last thing we wanted to just say is that there is a time and a place to refer out. So sometimes one of the reasons ERP isn't working is because the dosage isn't right. If I am really sick, sometimes I may need to go to the hospital for an intervention that requires me to stay there and get IVs and get a lot more, specific care than being able to just go to, Walgreens and grab a Tylenol and take that and feel better by the next day. And so depending on severity level, number one, someone needs to be very qualified to treat OCD and have really good training and background, not as much as I would love, but not, you just watched our webinar, right? But like, you really have had training, experience, expertise, supervision from clinicians who have done this work for a long time. So you're qualified. But number two, is it the right dosage? Somebody who has really severe to extreme OCD, so we're thinking about 30 plus on the Y box, maybe even 25 plus on the Y box, we wouldn't really expect them to respond to outpatient therapy. And so one of the things we want to think about is, Are they doing CBT is ERP is CBT, which means you're getting homework, right? You're getting assigned things to do in between sessions. Are patients struggling to do that independently? Or is it a game of whack-a-mole because every time their OCD is so severe they can't actually implement any of the concepts and they're just really struggling so much? But like if a patient is stuck, instead of saying ERP is the problem, is it the level of care that's the problem? And do you need to consider a more intensive program like an IOP, a day program like a PHP, or a residential program? And then the last thing I'll say is make sure if you're referring them to any level of care for OCD, that they are in an OCD specific program. So there's lots of residential programs in the country that will say they treat OCD, but it's among a list of 500 other things they treat. I want you to look at, does the program we're looking at specifically only treat anxiety disorders and OCD as their primary disorders they're treating? And this is important because we want the entire day, the whole treatment day, you're going for intensive treatment to get days long of treatment. We want that entire treatment day to be filled with evidence-based treatment, not, oh, you get 1 or 2 hours here and there, because then it's not that different than traditional outpatient care. But let's hop into questions. Okay, sorry, it's a little hard for me to read those. Can you read them?
Yeah, definitely. I mean, if a patient is not bought in, don't proceed with ERP 100%.
Yeah.
It's not going to work. What you could do is say, would you be willing, like we'll set it up as a behavioral experiment. Would you be willing to try ERP once with me together and see how it goes? You can always, if you're still not bought in, we can always pause. So you can try some techniques to see to build that buy-in through strategic things like that. But if fundamentally a patient is saying, well, I want to get over my OCD, but I'm not willing to do ERP. I don't want to expose myself to these thoughts. Then you would not proceed with ERP. You would either continue to explore like what are the reasons for and against that, make sure there are no gaps in the psychoeducation, or unfortunately, sometimes you just need to say, well, look, I think you have a really good understanding of, from my perspective, from an ERP perspective, what you need to do to get better. Currently, you're saying that's not what you want. That's totally up to you. Let's pause here. I'm available if and when you need me. Come back and see me. Patients will really respect you.
Yes.
And we've had some of our biggest successes when we've actually drawn that line and said, well, then why would we do this? We need to pause. You'd be surprised how many patients then go, you know what, actually, I'm going to give it a try. I think this is what I need.
Yeah, I always tell clinicians, I don't want you debating with a patient of why they should do it. Like, this is not a debate. You really want patients to be, you want to stay in psychoed long enough that they're convincing you it's time to do exposure, that they're like, okay, I'm ready, not you're convincing them.
Yeah, and then cyclical motivation, the second part of the question, that's pretty normal for most people. So kind of normalizing that, providing, again, psychoeducation around what is motivation. It's not really a feeling. We think of it as a feeling. We can feel motivated, but that's not really what motivation is from a CBT perspective, right? Motivation is a commitment. It's a choice that we make independent of how we're feeling, which is, again, another really important concept that we're practicing with the therapy overall, mood independent behavior. But you can kind of normalize that. I think if it's becoming treatment interfering in the sense that the patient, their motivation is so variable that they're not able to make consistent progress, that's when we would look at, is there a comorbid depression diagnosis? Are there other things going on? Do they need a higher level of care with more support?
So when you refer to freedom being the goal versus white knuckling life, are you referring to acceptance from an ACT perspective? I'm thinking anxiety may still be there, but the point is not to let it ruin the important things.
Kind of, this is a great question. I think that the question is like, when I'm talking about freedom, are we saying like just accepting, like using an ACT perspective to just kind of accept that, yeah, anxiety will still be there? And what I would say is like, maybe, maybe not. And what I mean by that is that sometimes I see people use an ACT approach where they will say things like, okay, the goal of treatment is to accept that you will probably always have anxiety, you're always going to have sticky thoughts, and you need to be okay with it. I actually am saying like that's not true and that doesn't have to be true. That doesn't mean you'll never have anxiety. It doesn't mean you'll never have a sticky thought, but I don't want you to think you have to spend your life feeling the way you're feeling right now or feeling the level of triggers you felt when your OCD is present there and making decisions for you in your life. And what we know is that when you do treatment effectively and you do the core fear work, you actually can get to a place where you don't meet diagnostic criteria for OCD, where you don't have thoughts that are any louder than my husband, who's like, why would I tell you my thoughts? That doesn't make any sense, right? We can get you to that place with effective treatment. So the answer is like yes and no. Yes, we want you to accept that it could be there. And because again, that means we're showing that we don't care. We don't care if anxiety is there. It's not going to make decisions for us. But I don't want you to actually think that the outcome and goal of treatment is that you will always feel high levels of anxiety. You will always feel triggers. And I say this because I think the way when we go from that lens, the way it's internalized for patients with anxiety and OCD is, oh, I'm always going to feel the way I do, and I just have to learn how to be
So then
okay
what's the
with it.
point of doing
Yeah.
treatment? Yeah, and the other thing that I would say is, again, if you're thinking about, from a CBT perspective, and ACT, of course, comes out of that, but if a patient is still ritualizing and avoiding, then I definitely wouldn't say, well, yeah, you just need to accept this level of anxiety, because that level of anxiety is created by the
That's right.
rituals and avoidance. If a patient has completely stopped all rituals, they're fully leaning in and they're not avoiding anything in their life, and they're still feeling some residual anxiety, which, happens sometimes, then yeah, okay, can we be okay with that? And if they can get to that point, the anxiety probably will go away. Whatever residuals left will go away. So yes, we use that technique, but again, more importantly, have they stopped the problem behaviors? That's way more important. Now, sometimes accepting can be a part of helping with those problem behaviors, but yeah, we're really looking at what are those maintaining factors? Have we actually adequately addressed them yet?
Yeah.
Okay, next question. So how do you manage ambivalence about not using rituals despite repeated psycho ed about the rush?
Yeah. So how do you manage ritual? Like if someone's still ritualizing even when you know and you've told them they need to stop.
Yeah, I mean, we could do a whole thing on this, but I love behavioral experiments. So, because again, we really believe that practical experiences are what teach people lasting. I can tell a patient all day long, you'll actually feel better if you stop the rituals. They're not going to believe me until they experience it. So I'm going to really say, hey, look, we've done this exposure 5 times. You keep doing some amount of rituals. Uh, let's do it again and let's try with no rituals just to see what happens. If they're not willing to do that, then again, I would say we should really pause, go back to psychoed.
Right.
Do they not understand something, or they're not willing to let go of the ritual? Fine, but then we're going to have to pause.
Yeah, and do they understand the function of the ritual, right? Right now, it's if someone's still doing a ritual, they think functionally it's making them feel better. And we need to slow down and help them see how it's actually keeping them more stuck.
Yeah, we love behavioral experiments. Let people come to the right conclusions through their own experience. Set up the experiment in a way that you're pretty sure that they'll get that if they follow through and do it the right way. But yeah, rather than me trying to convince someone, I just want them to find out for themselves.
Yeah, let's give it a try.
Let's give it a try.
Okay, next question. As I work with children and teens, when do you teach anxiety management skills as kids may feel they cannot tolerate anxiety prior to exposure?
Yeah, I mean, I teach anxiety management skills to my 1.5-year-old top twins, all the way to my 5-year-old. But like anxiety management skills start when kids are little, from if you sleep train to if you tell them no and they have to manage their distress and their anxiety around that, to when they're scared to try a new thing, whether it's walking or climbing up a ladder or taking a test, right? Anxiety shows up. We can't avoid anxiety or anxiety provoking situations. And in fact, if you try to prevent your child from having those experiences, you are really hurting them. You're fragilizing them and you're actually promoting anxiety, right? You're doing rituals. Like really at the end of the day, you're doing the same thing that a ritual does in the OCD cycle. So I'm teaching anxiety, anxiety treatment, how to approach the fact that we can do hard things, how to approach our fears early on. And we should be teaching that in therapy. We should be teaching it to kids. We should be teaching it to,
Yeah.
adolescents, to adults. It doesn't matter.
Absolutely.
We should be modeling it and teaching it all the time. But again, I want to kind of go to Ryan said this years ago, and I remember the first time you said it, I was like, I don't really, because I used to always use the analogy here of like, hey, you're gonna have so many tools in your backpack, and when you leave, like that invisible backpack you get to keep forever. And Ryan used to say, I don't really want them to have that many tools. And I was like, what? And because it was like the way I was saying it, but conceptually you could explain this. But I think that even the thought process of let me help you have a lot of strategies for anxiety versus let me just teach you that you can approach anxiety.
Yeah. Exactly. Yeah. And it's not about the tool or the one particular tool or skill. It's about the internal orientation, the relationship to the anxiety. With kids, you can use some scaffolding. Like we love positive coping statements that empower them. Like, yeah, I'm really anxious, but like I'm like Spider-Man, I'm strong, I can handle anxiety, which serves the effect of them kind of de-emphasizing the importance that it has or the power that they think it has. Sometimes we will give them a little tool or technique, but the purpose of the tool isn't actually anxiety reduction. It's
Bingo.
more to feel that they have control. They have like agency in
Yeah.
right. Like, oh, if I squeeze this thing, I can then do the thing. It's not about I squeeze the thing, I feel better, then I can proceed. It's like, no, I'm my own agent. Yeah, I'm brave. I can do these things. I have some say in the process. Anxiety's not in control.
Right. But be careful if what we're doing is trying to give people tools so they don't have to feel anxious or give them tools so they can feel better. Because again, what is the function of that? The function that the way that's internalized is anxiety is bad. I shouldn't have to feel it and I need to do things to reduce it. Where instead I want to teach you like, okay, when you feel anxious, be brave and approach it. And like that's the tool is brave, this
Yes.
concept.
Okay, next question is, I have OCD around counting my swallows or blinks forever. What would ERP look like for that?
Yeah. So what would ERP look like for blinking and swallowing OCD?
Yeah, I mean, we'd have you intentionally, blink and swallow,
Uncomfortable number of
yeah,
times.
have the thought that, oh, maybe I'll never be able to stop being aware of my blinking and swallowing, because that's probably what bothers you about it. Usually with the somatic OCD, the thought is the fear is not, again, the blinking, it's I won't be able to stop thinking about blinking or
Yep.
having to control my blinking, and that's super uncomfortable. It'll ruin everything. That's a scary idea. Is that okay? Can you expose yourself to that idea? Can you get good with like not letting your brain scare you with that? What would be so bad about thinking about blinking all day long, right? If you can get okay with that, then your brain will probably stop paying attention to your blinking. It'll be like, oh, no big deal. It's not a problem. So
So again, we're going to have you doing everything that doesn't reinforce that blinking and swallowing matters and that I need to be aware of it, right? So we're going to have you stop monitoring, stop doing it a certain number of times, but also when you're triggered, lean into the fact that like, I'm afraid I'm not going to be able to move on. I'm afraid I'm going to keep thinking about this later, and I'm still going to only do it this one time anyway. Also, there tends to be a lot of avoidance with that type of OCD of
yeah.
like certain foods or certain things that make us swallow more, so remove avoidance as well. Let's take one more question.
Okay, can you recommend any books for continuing to expand clinical knowledge on OCD or ERP space?
Yeah, I mean, if you want to throw me those couple books, I really like Freedom from Obsessive-Compulsive Disorder by John Grayson. If you feel like you need a better foundation for CBT, we really love the Doing CBT book by David Tolan. So, like, all of our new clinicians have to go through the CBT book and a full CBT course with us, a didactic that takes almost a year first before they're doing specific ERP work, because again, fundamentally, to apply ERP, you need to really understand CBT at its core. And then do continuing education. The International OCD Foundation has a behavioral therapy treatment institute called the BTTI. It's a 3-day intensive OCD specific training program. But I would also encourage you seek out specialty OCD programs and see if you can get some training and background. Maybe it's observation, maybe it's a job, right? But what can you do to help train and learn or get supervised from somebody who has a caseload specific to anxiety and OCD? All right. So as we wrap up today, thank you guys so much. We love the questions and we're actually here to answer them. So we're excited to announce that we will now be doing a Q&A once a month as well. So we're going to be doing our live kind of webinars that will always happen on the second, just like it did today. So they'll be on the second Thursday at noon Eastern time. And then on the first Thursday, so that'll start next month in July. I can't believe we're already in July. The first Thursday at same time, noon Eastern, we will be doing a kind of AMA case consultation. So Ryan and myself or some of our other clinicians from OCDI will be coming on. It will not be recorded, so you can come as a clinician. And this is where we're going to, of course, following HIPAA guidelines, so please don't share specific info, but we're going to do true case consultation. So we'll be here live to talk through cases, examples, ERP, things that you're stuck with, what to do, comorbidities, when to refer out, what to ask, all those sort of things. And we're really excited about that. And so we will definitely start with the questions at that first case consultation and then continue on with active case consultation. Thank you all so much for joining. I hope your takeaway from today is that anxiety is not dangerous. And across the board, we have to make sure behaviorally we are not reinforcing the opposite.
Yeah, thanks so much. We'll see you next time.